I'm Trisha Deering. I'm the director at Southwest Missouri AHEC, and we have Adam Bolyard here with us today. So I have a little introduction for him. Adam Bolyard is DO. He graduated with honors from KCUMB in 2013. He was a core student with Southwest Missouri AHEC here with us and completed his clinical rotations here in native Springfield. So we're glad to have him back in the area. He completed his residency at Wright State University in Dayton, Ohio, and is board certified in internal medicine. Adam is now a staff internist at Mercy Clinic, Smith Glen, Callaway, and his practice interests are general internal medicine and with a particular emphasis on providing evidence-based and high-value primary care. So Adam's topic today is osteoporosis, how to diagnose, who to screen, and who to treat. And we are very thrilled to have him present this morning. This afternoon, I guess.
Correct.
So you want me to go ahead and do the screen
sure.
share? Okay, we're going to do the screen share. So. Okay, can you all see that okay? See me? Okay.
Pretty good thumbs up. Okay.
Yeah.
All right. Good morning or afternoon to you guys that are here. Like Trisha said, I'm Adam Bolyard from Springfield. It's nice to be back. I remember when I was in your seats, though, we didn't get lectures like this, so it's pretty cool that they've started doing that. Anyway, so I guess your theme I hear this year is geriatric kind of stuff. So I wanted to pick a good internal medicine topic that is applicable to geriatrics, but it's pretty high yield for other things that you'll see too. So if there's any future orthopedic surgeons here or geriatricians or primary care doctor type folks, then this is going to be stuff that you see all the time. So I'm not going to do much of the pharmacologic treatment, though if you guys have questions or if anyone else somewhere at one of the off-sites has questions, certainly we'll get to that, and you can ask about therapy and all that stuff down the road too. But I'm going to really focus on how to diagnose, who to screen, and then how you decide if you need to start treatment or not. So, because not everyone with osteoporosis or bone thinning needs treatment. So, first off, let's see. I don't know if you guys have used Poll Everywhere before, so it's kind of an audience response type thing. So grab your phone or your computer or whatever you've got. If you have one that it's not like a smartphone, you can still do that. You can do like text in kind of responses. So it'll have the short phone number on the screen that actually has a question if you need to text in. Otherwise, you can do it on your web browser. So I'll give you a couple minutes to log on, and you don't need an account or anything. You just get on the website and it'll do it. All right, so they'll be on the website. Will be on the question slides too. So first off, definition. Osteoporosis is basically a chronic disease of progressive loss of bone density. Lots of different reasons that it happens, but it's pretty common. So, and then everyone loves a good Netter drawing. So that's kind of what the skeletal structure looks like. And then the posture over time of folks who have osteoporosis. It's pretty interesting when you get the bottom of the ribs that's touching the iliac crest. So etiologies, it's broken up into primary and secondary. So this is primary. There's juvenile and idiopathic. Juvenile osteoporosis tends to occur equally in males and females from age 8 to 14. They usually have normal gonadal function, normal endocrine function, but it's pretty much associated with trauma. So you get a fracture, you get some kind of injury, and then in that area you get osteoporosis. Then there's idiopathic. So this is the typical kind, either a postmenopausal or just the general bone thinning that you get as you get old. So that would be senile or age-related. And then, of course, there's type 1 and type 2 designation for that. So, etiologies, type 1 is like I said, the postmenopausal. That's an accelerated bone loss after loss of estrogen, or decrease in estrogen with menopause. Primarily the trabecular bone, the central part of the bone, rather than the cortical areas. And the fractures tend to occur in the back and in the forearm. Then that is compared to age-related, which is senile osteoporosis. That's just a gradual decline. It occurs in men and women, mostly women though. And it's both cortical and trabecular bone loss. Fracture patterns are a little bit different. So that can be wrist, also vertebra, and this is your hip fractures. So secondary, there's a hint as to one cause. So let's see if we can do some poll everywhere stuff. What are some secondary causes? So I see steroids, that was the first one. That's a good one. Uh-oh. Kind of like, there's the arrow. Cancer, rheumatoid arthritis, smoking, estrogen, renal failure. Good. Cushing's, of course. So I see a lot of endocrine stuff, a lot of rheumatologic stuff. Okay. Steroids being a medication, of course, probably used in chronic COPD people or rheumatologic issues. Rheumatoid arthritis can do it. So kind of darned if you do, darned if you don't, I guess, with that space. Nice. Okay. So let's move on to the list. It's a big list. Let's see. So there are genetic, endocrine hypogonadism is, of course, an endocrine problem. Then the deficiency states, I saw a couple, but there are some more. You have to watch out for bariatric surgery. That's a big issue. Not only vitamin B12 and other vitamin deficiencies, but calcium is a deficient mineral in a lot of bariatric folks. Of course, inflammatory disease, not just RA, it's always lupus, or never lupus, I guess, right? Inflammatory bowel disease also, don't forget that. A lot of cancers and hematologic problems can cause it. Then it's not just steroids on the meds. So SSRIs, other mental health medications like antipsychotics, anti-seizure medicines, and then some really common stuff like Lasix even can cause it because you get wasting or loss of calcium. So over time, that can cause some issues. And then there's the miscellaneous stuff, alcoholism. People who are alcoholics tend to have a lot of deficiencies and have a lot of problems. And a neurologist one time who said, it's just like the worst thing you can do because it affects literally everything. He was interested in the brain, but heart, GI, so liver, bone, all of this stuff is affected by alcohol. CKD I saw when you guys put that in, and a lot of other things. So epidemiology, as an aside, so this is one option for your older folks. If we've got any future geriatricians in here, you have the padded underpants, hopefully reduce a fracture risk. I don't know if it really works. Let's see. So osteoporosis, most common metabolic bone problem in the U.S. There's a lot of people that have it, and osteopenia or just generalized bone thinning is super common. Of course, the incidence increases with age, hence senile osteoporosis. And we all know that women are far more likely to get it than men. And then, as we'll see later, another major risk factor is white folks and East Asian ethnicities. So, who should you screen for osteoporosis? Low-hanging fruit. Yep. So women over 65, postmenopausal women to some extent, people who have compression fractures, yeah. Steroids reasonable. Okay, that's good. Hyperparathyroidism, osteoporosis in hyperpara is a reason to take the parathyroids out. And pathologic fracture, good. Okay, so that's a big chunk of them, good. So this is lifted from the American College of Clinical Endocrinology or endocrinologists guidelines for osteoporosis. This is the general recommendations. Of course, we start screening at age 65. And then all postmenopausal women with some other criteria. So if they've had a fracture without major trauma, if they have osteopenia that they got, gosh, of course, everyone goes to the ER for, I don't know, if they go for back pain or something, and they do some imaging, and then the radiologist says osteoporosis. Is that really osteoporosis? It's hard to say. Actually, no, you need true osteoporosis screening testing, not just a regular plain film. So there is, of course, indication, which is why you see it. And then people with steroids, we'll get into that a little bit more later. And then other perimenopausal or postmenopausal women with risk factors. So I think someone said in the text in, so if they're low body weight or an eating disorder or something like that. But that would also include people like with emphysema. I don't know, the pathology guy, was Irv still there when you guys were at, okay. You always call them the blue bloaters and the pink puffers. So the emphysema people, the little tiny pink puffing people that have like a BMI of 18, that they would need osteoporosis screening. So anyway, that's a tangent, sorry. Again, steroid use, family history even plays a factor. Early menopause, smokers perimenopausal women who are smokers should get it before 65. And then again, alcoholics or anyone who has secondary osteoporosis. So diagnosis, let's see. Okay, so DEXA, or dual energy X-ray absorptometry, is the way that we screen. Basically, that's, I don't know of another way that we routinely screen. So typically it tests 3 different sites. It kind of looks like almost like a mini open MRI or something like that, if you guys have ever seen one. It's got this little C-arm thing that goes over and shoots X-rays through a particular part, and the sensor checks how much is absorbed, essentially, and comes out with a number. So the sites that are typically tested are lumbar spine. Then you'll see like the total hip, and then like a subcategory for just the femoral neck. So that's really looking at the areas that we care about, right? So compression fractures in the back, so you look at the spine, and then hip fractures. So then there's actually data out for the medications that we use, because some are effective against lumbar spine, but not the femoral neck. Like, you guys know Boniva is effective at preventing lumbar compression fractures, but not so much hip fractures. So it just depends. So you kind of have to pick your medications sometimes based on the results, or this can be an indication where the problem's at. But anyway, so frequency of DEXA. I don't think I put a poll everywhere slide for that one. So you guys in here, how frequently should you check? So we do it once when they turn 65 or whatever. Any thoughts? I'm here in year.
3 years.
3 years. You guys are just as confused as me. I'm going to be honest. There's no guideline that says you should check every year. You should check every 5 years, at least that I've seen. It's your clinical gestalt. I don't know. They leave it for that art of medicine kind of thing. It depends, really. But everyone should get one when they turn 65 or when they meet one of the other criteria. And then based on that, you can decide how frequently you need to do it. If they're on therapy, sometimes you monitor the bone density increase. It just depends. So And then as an aside, because it's not on here, someone gets a fracture, you don't check the bone density right away. You have to wait. Usually the orthopedic surgeons will say a couple of months. It depends usually, but you kind of delay that so that the healing can happen, because oftentimes if it's a hip fracture, you're going to want to check that area anyway. So you give it some time. So what's the difference between T-scores and Z-scores? This is multiple guess. Moving target. I think we've pretty well honed in. You guys picked B. No one got like D. That's what I would usually pick, I guess. All right, T-score versus Z-score. Let's see if you guys are right. So T-score is a measure of the patient's bone mineral density compared to that of healthy young adult references. So you guys are opposite. That's okay though. So T-scores are what you use for older folks compared to generally healthy young adult reference ranges. Z-scores are a measure of the patient's bone density compared to their age, gender, and ethnically matched, age-matched peers. So, interpreting DEXA results. So, we use the WHO classification for most folks. Really, it's only useful in women in general over 65. So, those postmenopausal women are the ones that we primarily use it in, especially 65 and older, like I said. So use the T-score. So that's basically comparing what's the loss over their lifetime. What would it be when they were healthy and younger, 30, 35, something like that, compared to what they are when they're 65. So osteopenia, or just generalized bone thinning, is from a T-score of less than from negative 1.0 to negative 2.4. And then osteoporosis is less than negative, or 2.5 or less. And then severe osteoporosis is osteoporosis with the fragility fracture. So that's how the WHO says we define it. Then in premenopausal women, we use that Z-score. So you're comparing them or her to people her own age. Right? So if someone is 40 and comes in with a fracture and you're concerned that she's got osteoporosis for some reason, say she's got rheumatoid arthritis, and you compare her to someone her age, her ethnicity, that kind of stuff. So clinical diagnosis of fragility fracture has occurred, like I said, so those are the people you're concerned about. Osteoporosis, or if they have a risk factor, like I said, rheumatoid arthritis, and you test them and their bone density is low. So what's a fragility fracture then? Someone wrote pathologic fracture before on one of these things. Someone see the YouTube video. All right. Yep, that's right. So fall from standing height, technically without trauma. So standing height or less without major trauma. So think back to that cartoon I lifted from the internet. The old person that fell versus the young person in the car. So car wreck would be major trauma, but a fall would not be technically major trauma. So what about men? Over 50 years old, just go ahead and use that WHO classification. Treat them like they're as if a postmenopausal type situation, though of course that's not the case. But less than 50 years old, it's also similar to younger women. Use decreased bone mineral density. They say, at least in a couple of the references I saw, they kind of go for 2. So solidly osteopenic, but fragility fracture plus the risk factor also in men that are younger. So you have to have more criteria, I guess you would say, for younger men. So then indications for treatment. Osteoporosis by DEXA, imagine that, right? So fragility fracture. Just having fragility fracture in a lot of folks is a reasonable reason or a reasonable indication for treatment. They don't even have to meet the diagnostic criteria by DEXA. You may consider treating them. And then the T-score in that osteopenic range with a FRAX score, which we'll talk about, indicating an increased risk of hip fracture or any major osteoporotic fracture. So think wrist or forearm or something like that. And then treating for prevention. Sometimes that's reasonable. So are you guys familiar with the FRAX tool? Fracture risk assessment tool. I see a couple nods. Let's see. So let's go to the website. And this is off the University of Sheffield in the UK. They're the ones who kind of manage this, but this is all based on the WHO recommendations. So just remember, since this is housed in the UK, everything is in metric or SI. So there's nice little conversion stuff on the side. So let's do a couple of these to give you an idea of how we end up treating folks. So let's go with a typical 65-year-old person, female. Give me a weight. Shout one out. Doesn't matter.
140.
140, I like it. Let's go with pounds, right? It could be kilograms. So that's about 63 kilograms. Height, say she's 5 foot. Okay. So just screening test. So she's never had a fracture or anything like that. We're going to assume no parent with a hip fracture. Maybe we don't know what the family history is that closely. Let's call her a non-smoker, just relatively healthy person, no immunologic problems or inflammatory diseases, not on a steroid, not an alcoholic. And then she's 65, so we did the DEXA scan, and there's lots of ways that it's reported, but in the US we use T-score. Pops up and says, T-score, don't use it for younger people. And then we'll say your T-score is negative 1.5. So you calculate this out, and her risk for a major osteoporotic fracture is 8.8%, and hip fracture is 0.9%. So if you recall, if they don't have osteoporosis, they don't have fragility fracture, this is just based off of screening, then you've got either a hip fracture risk greater than 3% or 20% for any osteoporotic fracture. She doesn't meet that criteria. Okay? Let's try and force her to get treatment. What do you say? So let's make her a smoker. Say her T-score was... That's my keyboard not working. Ruh-roh. Okay, 2.3, what do we say? Of course, let's make her drink too. And maybe she's got a family history. Okay, so we calculate that, and by all accounts, she needs bisphosphonate therapy. Okay, so major osteoporotic fracture is greater than 20, and her hip fracture risk is greater than 3. But there are some things. I've got a couple patients who are otherwise really healthy. I've got one lady who's about, how is she, like 82 maybe? Super thin lady, like say 120. I think she's about 5 foot tall maybe. She does have RA, and on a little bit of steroids. I think she's only on like 1 milligram, so that doesn't really count. So let's see what her risk is. So 22% still, a lot due to her age, you know, and the fact that she has RA. What would it be without RA? So not that much different. She'd still get it by the hip fracture. So that's the gist on how the Frax tool works. It's really useful for folks who are kind of in that gray zone, and then I usually port that into my notes and can follow that over time. In 3 or 4 or 5 years, when we recheck your DEXA, we can go from there. Okay. So there's that, and then a moment on roids. So not those kind of steroids, glucocorticoids is what we're talking about. So anyone that's on steroids, kind of the cutoff is 3 months. Okay. So rheumatologic people, say someone who has temporal arteritis, giant cell arteritis, whatever you want to call it, or polymyalgia rheumatica, or for some reason they ended up on steroids for their COPD or something crazy, super long taper, I don't know. So 3 months or longer, this is kind of the cutoff, okay? And it's not just they've been on it for 3 months, it's you'd anticipate it. So that's particularly the giant cell arteritis kind of people who are definitely going to be on it for like 2 years, something like that. Super low taper, super slow taper. They need something, okay? So they should all have calcium and vitamin D supplementation. And this is not just older folks. This is, if I was on steroids for RA or something like that, I would need calcium and vitamin D, just as a preventative measure, essentially. All right. Then we use pharmacologic therapy if a patient meets a reason to do it. So if they're 65 and have osteoporosis or whatever, or you anticipate that they'll need steroids for 3 months or longer at a level of 7.5 milligrams or more. It's like polymyalgia rheumatica. They might end up on steroids of like prednisone 20 milligrams for a year and a half with a real slow taper. And you go from like 20 to 15 a couple months later, to 10 a couple months later after that, to like 8. And, you know, they end up on it for a really long time. So you would actually give them a bisphosphonate just for that, to prevent the development of osteoporosis. Or if someone doesn't meet the criteria, like they're on steroids, like 5 milligrams of prednisone or like the equivalent for 5 months or a couple of years or something like that. There's some RA people who end up on 2 milligrams of prednisone. Like that's like almost homeopathic, you know? So it's sub-physiologic. Around 5 milligrams is equivalent to what your body would normally make, okay? So that's like less than what your body would normally make, but it's a little extra prednisone or a little extra corticosteroid. So in those people, that might be a reason to check a DEXA in a year. And if they lose like 4% of their body or bone mineral density, then you put them on a steroid. Or, sorry, bisphosphonate. They're already on steroid. That's the reason. So does that make sense? So if they have quote-unquote accelerated bone mineral density loss of 4% per year or more, then they would also get a bisphosphonate or something. Okay? So that's a little extra stuff. And actually, as someone in practice, I know we forget about this stuff all the time. So the rheumatologists are pretty good. This comes from the rheumatology guidelines. They're pretty good at preempting this kind of stuff if they're on steroids for their RA or something like that. Okay. So these are the references. The AACE and the ACR are really good references for guidelines on this kind of stuff, especially the endocrinologist. If you need a specialist for osteoporosis, which primary care doctor probably shouldn't, hopefully, but the endocrinologists are your specialist for this. So, and then a bunch of other stuff. All right, so questions. We've done 10 minutes early, so got lots of time for questions. Treatment or how the guidelines work or anything like that. All right. So how about I ask this? So I mentioned one of the types of therapy. So that's bisphosphonates. How do we generally treat people with bisphosphonates? What's your first line bisphosphonate? How about that? Let's do that. Send that in. Correct, whoever you are. Both of you. So alendronate or PO, yeah, it's Fosamax is your first line. It's once a week, so pretty convenient. How long can you take bisphosphonate? Generally. Five years. It's pretty good, actually, roundabout time frame. You want to do kind of cycles of bisphosphonates, essentially. So you do like 5 years and then give someone a break. You guys know why? How about this? How do bisphosphonates work? Do they increase your production of bones or decrease the absorption of bones? You know, our bones are in constant skeletal structures are in constant cycling. Right, so whoever said it inhibits the osteoclast, so basically you're decreasing the amount of bone resorption. So those last answers are right, or now they're moving around, so who knows where they're at. Okay, so there is a concern about osteonecrosis of the jaw, and this comes up super commonly. I don't know, I'm going to say like 5% of the people, at least 5% of the people I offer bisphosphonates to or recommend them to, I'm like, no, I knew this one person one time through my dentist who said bisphosphonates are bad because their jaw fell apart or something like that. It does happen. I think I've seen like one case maybe in residency of it. It's very uncommon, but it's certainly a concern. There are other side effects and issues that come up with alendronate. So what's the most common side effect of bisphosphonates, like alendronate, basically? Let's see where it's going to pop in. Esophagitis, GERD, GI. That's the gist of it, yeah. So it's all the GI upset. That's the most common intolerance to it. People take it for a couple months and they come back and they say, like, I'm puking all the time, or I got horrible GERD. So what you do about that, when you start it, you blanket say, stay upright after you take it for 30 minutes to an hour. The pharmacy folks are really good about making sure they give people instructions on how to take Fosamax properly to decrease the GI upset risk. So, but what if you try that, you keep getting GERD, or you get esophagitis and can't control it? What do you do? Don't get what? Okay, PPI. Switch the medication. Naloxone, yearly injection. So the gist is switch the medicine to something else. So I like the yearly injection. There are yearly options of bisphosphonates. That one is zoledronic acid or reclassed. It's nice. It's an infusion. You do it once a year. You do it 5 times, and then you stop. You can switch to another. Raloxifen's a possibility. Prolia, which is, I can never. Now I get into practice, and I've already forgotten all of the generic names, right? Prolia. Can someone beat me to it? Denosumab. So it's a monoclonal antibody. So that's another good option. And there's one other. I'm blanking on the name right now, sorry. Anyway, so you switch. After the 5 years, you don't have to stop completely. So you could do Fosamax or reclassed or something else, even Boniva if you still do that. Some people do for 5 years, and then you stop it. And you can give them a break for a couple of years, but you can still, if they've got really bad osteoporosis still, you can switch to Prolia or something like that. So someone wrote calcitonin. I guess that makes sense. Theoretically, it's an option. Usually we use calcitonin for what? Okay. Hyperpara, yeah. So hypercalcemia of malignancy, that's an option for that. And bisphosphonates are also first line for that too. So you have someone for some reason who has multiple myeloma and gets high calcium, or has prostate cancer and gets a fracture, so for some reason they get, or lung cancer and get hypercalcemia. You can give zoledronic acid, the short version, short acting, or calcitonin for hypercalcemia of malignancy. Okay? As I'm stalling, does anyone have questions? You're welcome to stick them in, or anyone here, shout them out. Is that a question, atypical neck fracture? No, or did that? I'll keep switching around from here, see if I can find a question. All right, well, no one's got questions.
The poll's full, I can't answer.
Oh, there's a problem. Let's see if we can do this. Here, buy a plan. Let's start a new poll. What do you say? I don't like that. new one. Maybe? There we go. Any questions? Sorry, I'm going to make you retype them. Calcitonin for vertebral compression fractures. I've not read that in the guidelines, and I haven't seen it used. Haven't used it myself, I guess. Usually, compression fracture treatment, it's kind of one of those, it really sucks. First line, it's pain management, and that's really frustrating for patients to hear sometimes. The data behind kyphoplasty is not so great sometimes. I've got a lady who's had a compression fracture like L1, they kyphoplastied it in IR, and then she, like 2 months later, had a compression fracture on either side of it. So sometimes when you have really bad bones, the kyphoplasty causes, it's like a domino effect almost. So, ooh. That's probably the cheapest one, because past that it's Boniva, which is some other Nate medicine. I forget the generic, I'm sorry. So unfortunately there's not a lot of options for folks, though. If they have a supplemental plan to their regular Medicare, that can be pretty helpful. Or some of the newer options you can get, I don't know, the drug company will help pay for a lot of that stuff if it's one of the newer ones. So usually alendronate's the best option. And then, of course, just calcium and vitamin D, and then get a pair of those padded underpants. I don't know. When do you repeat DEXA scans after initiating treatment? I would give it 1 to 2 years, probably. Very neat. Don't forget to go to the meeting. Let's see. So usually 1 to 2 years to see if there's much of a difference, and then continue therapy. Risk of clots, DVTs, a couple of docs won't prescribe. DVTs can be tough. Let's see. From my standpoint, I would probably want to know why they got a DVT. If it was provoked or unprovoked, and then maybe be more cautious, I guess, if it's unprovoked. And then if they had like a cancer or something like that, or they had a surgery previously and got a clot after that, I'd probably be less apt to be concerned about it. So blanket saying, no, I won't give it, I probably wouldn't. So I think that was all 4 of those. Okay. Well, thank you.